A 21-year-old male presents with persistent right ear discharge and hearing loss. You quickly check his vitals, temperature, blood pressure, heart rate, O2 sat, and they are all completely normal. There's no fever, no systemic distress, just a weeping right ear and a noticeable drop in hearing. So let's get right into the workup.
All right, let's dive into the history using our clinical reasoning to rule out immediate threats line by line. First, no history of chronic illness or immunodeficiency. Well, that instantly lowers our suspicion for a severe, rapidly spreading infection. No recent upper respiratory infection. That pushes acute otitis media way down our list. And crucially, no diabetes. Why does that matter? Think about it. Because diabetes is the classic risk factor for malignant otitis externa. You know, that devastating, bone-destroying infection. Since he's non-diabetic, we can breathe a huge sigh of relief.
Moving down the patient's history, the absolute absence of visual changes brilliantly illustrates that we can cross orbital spread right off our differential. Infections of the ear and sinuses can rapidly track toward the eye, but our guy, he's got perfect vision. Also, no recent trauma or foreign body means we aren't dealing with a ruptured eardrum from a Q-tip. And no prior ear surgeries confirms we're looking at native, albeit highly inflamed anatomy.
Okay, let's look directly at the raw physical exam notes. Pay close attention to the exact phrasing here. Purulent discharge and perforated tympanic membrane on otoscopy, specifically in the pars tensa. That anatomical location is quite literally everything. A perforation in the pars tensa combined with chronic purulent discharge points aggressively toward chronic middle ear disease.
Now, what's really fascinating here is how the lack of mastoid tenderness instantly rules out mastoiditis. That keeps our focus squarely on the middle ear. Because if that mastoid bone behind the ear was swollen, we'd be dealing with a surgical emergency. Even more reassuring is the fact that there's no facial nerve palsy. Remember your anatomy? The facial nerve runs directly through the middle ear space. An aggressive infection would compromise it, causing facial drooping. But our patient's face is perfectly symmetrical.
So here is the absolutely crucial takeaway. A normal fundus exam and a complete lack of nystagmus confirm that this is a safe tubotympanic disease. There are absolutely no inner ear or intracranial complications. Nystagmus would mean the infection had breached the inner ear's balance centers. A normal fundus? That means no increased intracranial pressure. The brain is safe, the inner ear is safe, this infection is strictly localized. Our investigations confirm our clinical suspicions perfectly. Audiometry shows conductive hearing loss in the right ear, which is totally expected since the eardrum is mechanically perforated. We take a swab, and the culture isolates Pseudomonas aeruginosa. That is the absolute classic microbial culprit for this condition. Finally, a temporal bone CT scan reveals soft tissue density right in the middle ear space. And this brilliantly illustrates the vital difference we look for on the CT scan. Our safe case shows soft tissue without the dangerous bone erosion seen in conditions like Cholesteatoma. Cholesteatoma is your classic unsafe ear disease, right? It acts almost like a localized tumor just eating away at the ossicles in the skull base. But our patient's CT shows completely intact, healthy bone. No erosion means no cholesteatoma.
Let's pause and think for a second. Do we need an MRI here? You might be super tempted to order one just to be absolutely certain, but the answer is a hard no. You only order an MRI of the brain and orbits if you suspect intracranial complications. Our clinical exam already proved there are no visual changes, no facial palsies, and a totally normal fundus. Trust your physical exam. Getting an MRI here would literally just be a waste of resources.
Now, when you're forming your differential, you might consider eustachian tube dysfunction. But remember the key difference. Eustachian tube dysfunction is just a mechanical failure, like a blocked drainage pipe. It's an underlying cause, not the primary infection itself. Our patient has the actual active disease state causing persistent pus to drain through that ruptured eardrum.
So piecing it all together, the pars tensa perforation, the chronic purulent discharge, the Pseudomonas, and the completely negative neurological signs, our undeniable diagnosis is tubotympanic chronic suppurative otitis media, more commonly known as SAFE CSOM. We call it safe because it doesn't carry that massive risk of bone destruction associated with unsafe adicoantral disease.
Okay, let's build out the management plan systematically. Step 1 is paramount. Oral toilet. You absolutely must use microsuction to clear out all that pus and debris. Why? Because if you just hand the patient eardrops, those drops will sit uselessly right on top of the pus. Once it's clean, we use topical ciprofloxacin drops to target the Pseudomonas.
Add in some strict water precautions, advise against smoking, and eventually, once that ear is completely dry, we can offer an elective Myringoplasty to repair the drum. For those high-yield exams and for stellar clinical practice, you need to remember exactly what not to do. Oral antibiotics are completely unnecessary for uncomplicated, safe CSOM. Topical drops deliver a massive concentration exactly where it's needed without any of the systemic side effects. Additionally, do not prescribe acetic acid. While it's highly effective for mild otitis externa, it is absolutely not the standard of care for a middle ear infection like CSOM.
All right, let's lock this in with 5 rapid-fire exam pearls that summarize the high-yield concepts of safe CSOM. Number 1. Safe disease involves the pars tensa. Unsafe involves the atticoantral region. 2. Purely conductive hearing loss is the hallmark of safe disease. 3. Pseudomonas aeruginosa is the classic microbial culprit. 4. Oral toilet is mandatory. Drops do not work through pus. And 5. Normal, neuro, and fundus exams are your clinical green lights for an uncomplicated status.
But I want to leave you